support and help or whatever you require. So Praveen is really has been a Thai junkie, I call it, for many years. He's been helping, volunteering his time. And then our other co-chair, he's traveling in Asia. He's Dr. Mudit Jain. He's a partner with Life Sciences Partners. It's a venture firm focused on medical devices. And so he has worked with Praveen to organize these our life sciences events here. So with that, I would like to hand it over to Praveen and to our great panelists over here.
Welcome, guys. Thank you for spending the evening here away from your family. That's the first sign of commitment for entrepreneurs. And we have great panel speakers today. The challenge of working with doctors, one of our speakers, Dr. Jordan Slade, his patient got admitted to ER in San Francisco a few hours ago. So he texted me that he'll try to make it, but not sure whether he'll be here in time. In any case, what we have, the format today is that we are going to ask each of the speakers to introduce themselves and their company, and then quickly get into question and answer sessions. And because historically all of you guys are, not shy and very engaged and involved audience members, I'm not going to be moderating this panel because it should be about you and your questions and not about the moderator-led questions. Feel free to ask questions, when the Q&A session starts. To introduce the speakers, the first, is Rick Altinger. He's VP of Product Management at M2U Health, and he's been doing technology for 20 years and specifically healthcare technology for 15 years. He was involved in launching provider services for M2U Health and also the acquisition of MedFusion, which was a $91 million acquisition in May of 2010. And he's got some great slides and presentations for you to set up the topic. After that, we have Judy Wade. She's the President and CEO of AliveCore, which is a phone-based, smartphone-based EKG device. And she actually has a prototype here, would be great to watch. She has background in gaming and entertainment and mobile devices. And then we have Matthew Douglas. He's the co-founder and VP of Engineering at Practice Fusion. And I understand, coded for 72 straight hours to launch Practice Fusion. So, he's responsible for all of the architecture and, maintenance and, engineering technology behind Practice Fusion, which is a free web-based EHR. So without further ado, I would, ask Rick to come in and start the session.
Hi, can everyone hear me? So I think we'll go without slides to make it a little easier and more interactive. So I work at M2U, the makers of TurboTax, Quicken, and QuickBooks. As you all know, the smaller division is in the patient portal space, and we got into it, as was mentioned, via an acquisition a couple years ago. And let me start with what's a patient portal. So a patient portal is something that providers pay for to help them interact more efficiently and effectively with their patients. And we're paid by providers on the order of what averages about $60 per provider per month. Today we have on the order of 40,000 providers. And when I say providers, I mean both MDs and nurse practitioners. The bulk of them are MDs, the vast majority of them are MDs, but we do have clinics that are dominated by nurse practitioners and such. And we go to market through electronic health record system companies. Some electronic health record system companies like Allscripts, which is our largest partner, and they're a $1.8 billion electronic health record company, basically partner with entities like us to do this. Others like Epic, one of the largest that's used by Stanford and Palo Alto Medical Center and Kaiser, do it themselves, and Matthew will, is another, his company isn't one that does it themselves. So a patient portal, basically the functionality that it has in it starts with things as simple as doing an appointment request and making appointments, filling out your forms. So this is the beginning of patient engagement, and we follow the jobs methodology. So we're solving a job for both the patient and the provider. For the provider, it averages about 5 phone calls to make an appointment, of back and forth, average. So there's a lot of cost tied up in that. So just with the appointment request process, and I say appointment request because most providers don't want to, despite ZocDoc's success, most providers that we offer real-time scheduling to don't necessarily want that. And so it starts with that in the workflow. It could also start with the provider sending out a message saying, you made an appointment by phone, please come online, set up an account, and fill out your pre-admission forms so that you don't have to arrive a half hour early and fill out all these forms. So this adds value, it saves them time, patients demand it and want it, and for providers it is also increasing the stickiness and engagement with patients. And so there was a study out just a couple weeks ago from Kaiser that showed that for any individual that interacts with them online and that interacts with the patient portal to do appointment management or prescription requests or to look at their lab results, that person is 2.6 times more likely to renew with Kaiser. And as provider organizations get larger and larger, this loyalty factor driving you to, in my case, it's all about Palo Alto Medical Foundation. They want me to go there. Well, the El Camino Hospital is close by as well, and they have a network of doctors that they're enticing me to go to. Stanford as well. So they're all vying more and more as organizations get larger and larger for my business. So this is an increasingly important thing. Most provider organizations either have, or actually only on the order of about 20% of provider organizations today have an interactive patient portal, but most, on the order of 55, are planning to implement it. And now there's a government regulation called meaningful use. How many in the audience have heard of the term meaningful use? So about half. So this is not part of Obamacare. This is part of the American Reinvestment Act that was put into law in the early part of the Obama administration. And on the order of $45 billion was set aside for provider organizations that adopt and meaningfully use an electronic health record system. So it requires them to do on prescriptions in the system. It's basically getting rid of the paper records. One of the provisions now of meaningful use 2, the second stage of it, is basically providers have to implement a patient portal to interact with their patients. And the specific element that's very interesting for entrepreneurs is they're required to share a copy of the clinical data and give patients the ability to view, download, and transmit their data in a codified, structured format. And that format's called the continuity of care document. So we now already are processing tens of thousands of continuity of care documents. We've got about 5.5 million patients on our system. And so we're already, even though it's not a requirement yet, processing a fairly high volume of these documents where after you leave the office, depending on how it's set up, in some cases before you even get out of the office, you get a notification via email that here's a summary of your care. It might be a couple days later that you'll then get an update with the lab test results. So we're getting a lot of rich data now that's in a codified, discrete format. And so by codified, I mean it's got, it doesn't just say what the procedure is, it gives us a CPT code. It doesn't just give you free text with the prescriptions that you're on, it gives us the NDC codes for the drugs. And so we're bringing that rich set of data in, presenting it to patients. And then some of the more interesting stuff that we're doing now is on the platform, we're allowing and working with third-party companies to offer applications. And so we're not going to develop clinical applications ourselves or an application such as what you'll hear about next. But we're very interested in enabling them on the device. And so how that would work, for example, is the app that we've got in testing right now is a diabetes care application. And so when the patient is with the provider, or later, but right now the biggest use case is you're with the provider, you either have or you were newly diagnosed with diabetes, and the provider says to you, I'm going to prescribe this diabetes care application to you. And you're going to get an email from me. It works with your existing glucometer, because a bunch of them, there's a number of these companies that are out there. This one in particular, though, is showing, that we're working with, is showing some early strong results of getting diabetes in better control. It works with your glucometer, and it's going to help you track your data and your diet and keep track of how you're doing relative to also the lab tests results that you're having done on a regular basis in the office. So the doc uses our system, which is a patient communication device in essence. The patient receives an email from their doc. The patient can then look at that, click on the link, and basically single sign-on over into this diabetes care application. And we then also are getting the patient's permission. Technically, we don't absolutely need it, but we, being trying to maintain the stewards of data here, we get the patient's permission, and we share the continuity of care document data. So the diabetes care app then gets this rich set of data with the patient's gender, date of birth, what zip code they live in, their past lab results, what prescriptions are they on, what diagnoses do they have, so are there other diseases that they're dealing with. So they start out with a rich set of data, and then the patient basically interacts with this app. They're reminded to check their glucose if they don't do it. The glucometer feeds the data up into the cloud and analyzes the data, prompts them to do different things, prompts them to answer questions about their diet. If there are problems, it alerts the doc, and we handle the messaging of that directly into the electronic health record system. And then on a periodic basis, in this app's case, it's monthly, we send a summary report to the provider. And so the next time they're seeing their nephrologist or their primary care doc, the doc has that information in front of them, inside of their electronic health record system, basically, so that they can then interact and know what's going on. And in some cases, they can change the care parameters, change the prescription and such. So this type of app is very exciting because it's engaging patients in their clinical workflow. The stuff we've been doing in the past is a lot of administrative transactions, right? Appointment requests, forms and such. And we do prescription renewal requests and such, but this is really starting to engage the patient with their trusted provider in a disease management app. And the same sort of workflow can go for other types of apps, or maybe an EKG type monitor to foreshadow a little bit, type device that a provider wants their patient to use. So there's lots and lots of these companies that are showing traction, and we have set a threshold that we will only work with companies unless they have at least 50 practices that have or are using their system, and at least 500 patients that have used it, and that they're showing some good results associated with that. So that's a brief overview of what we do, and one of the more exciting aspects of healthcare to me is with meaningful use and the sort of liberation of the data that's taking place for patients.
Can you hear me without this?
No.
Oh, okay, darn. So how many of you know what an electrocardiogram is? Most of you? How many of you have had one? Yeah. So those of you who've had one, there's really electrocardiogram, for the few of you that don't know, is really a measure of the electrical system of your heart and the rhythm of your heart, which is sort of the primary train conductor for moving blood throughout your body, both out and then back in. And it's typically used to diagnose everything from arrhythmias to congestive heart failure, heart defects, and heart disease. And single lead and 12 lead, and then if you had 12 lead, you've seen how you get sort of hooked up, and you have to, oftentimes, it's probably an hour in the hospital. The single lead ones are often sent home with you after you've been diagnosed with something quite bulky. We were actually talking to another provider of an event holder as they're called, and These are people who actually have an issue, need to be monitored, and most of them take it off after a week, even though they're supposed to keep it on for 2. So quite bulky, fairly high cost if you're talking about ones that you might take home. And a live cord, the reason I was going to see if you could hear me, because it's hard to, yeah, there you go. And maybe I'll just try and talk loud. So our product, by the way, is not yet for sale in the United States. We have not yet received clearance. We expect that to happen at the end of the year. But this is our first initial product. These are 2 electrodes. There's an app that you download from the iTunes store. You launch that app, and then maybe, ta-da! There's some irony here that these guys get to be Carol Merrill, and I get to be, oops, sorry, let me just get my phone back. There we go. And maybe not. Sorry. There we go. No, maybe not. That's weird.
Showed it to me earlier.
I know. I don't know why. Oh, there we go. Okay. There we go. I have it upside down. And that's clinical quality ECG. It's been compared to Mac 5500, which is a GE machine, and it's 0.997% is accurate. After 10 seconds, the data is stored on the phone, and then as soon as you finish, it goes to the cloud and is instantly available on the on the web for analysis anywhere in the world. So that's our first initial product. We have 3 others in development. We've actually already launched in the vet market. It ends up there aren't really any solutions in the vet market that, to speak of. And you can kind of say, so what? But our goal is to really make ECGs as accessible as blood pressure screening. Atrial fibrillation, there's 2.3 million people who are diagnosed with that in the United States. And they believe for every person who's diagnosed, there's at least 1 to 2 people that aren't diagnosed. And it's one of the leading causes of stroke. We also have clinical researchers that have started with IRB's clinical research to actually use our device to look at longitudinal research to help actually look at predictive measures for things like congestive heart failure and heart disease. But our real vision is, I think, to take advantage, and I think a lot of the other products that are more in the mobile sensing market are really to put care in the hands of the patients. So that right now, if you think there's something wrong with you, you end up in the ER, or often you unfortunately end up with a stroke. Leslie Saxon, who's the head of cardiology at USC, led one of the clinical trials for our device, was playing tennis with a USC tennis player who was 20 years old, and she sat down on the tennis court with a racing heart, which every time she then went to her doctor to have looked at, there was nothing there. And Leslie Saxon actually took out our device and used it, and she had a heart rate of 220. And she probably could have been one of those people that might have ended up later. Yes. So what we really want to do is actually use our device as a universal screening device, and then also for education, so that a patient, as they're out in the world and other devices like ours, you're actually, you have your phone with you everywhere you go. You can actually have caffeine, a shot of espresso, and then realize that that's actually triggering your arrhythmia. You could imagine that you walk into Starbucks and Siri reminds you that you should be maybe having the decaf today. You can imagine that you're in a bar and it reminds you that you might want to watch how many cocktails you've had. So our kind of vision is with our products, and this is again only our first one, we've already actually been able to use our technology to, without any additional cost to thermometers, to actually add instantly after you've taken your temperature to have that uploaded to the cloud and available anywhere, is that we are really going to, with our devices, make sort of healthcare kind of in the hands of the patient that could also then be used via our website to be diagnosed by healthcare professionals somewhere else, but to really put in the hands of the patient the information and data they need, much as you talked about with diabetes, that they need to actually take kind of more power over their own health information and health education. So.
Thanks, Judy. So my name is Matt Douglas. I am co-founder and VP of Engineering at Practice Fusion. We are a free web-based electronic health record for doctors to manage their practices. We're also a free web-based personal health record and patient portal for patients to manage their own health online. Somewhat similar to what Rick's products provide to the other EMRs in the market. We started in 2007 with just an idea that from the day you're born until the day you die, all your medical information is available in one place for any medical professional to access. When my co-founder Ryan pitched me on that idea, he and I had just been introduced, and I was looking for a startup very early stage, and boy did I get one. He pitched me on this idea, and the moment that he said it, I was hooked. I knew that this was a big problem that needed to be solved. At the time, we could all go on Facebook and tell the world what we had for breakfast, or we could go to our online bank and check our, or on Mint and check our balances. But none of us could really do probably the most important thing in our lives, which is track our own health online. So that purpose, that mission really spoke to me. And here we are 5 years later. We have about 46 million patients on our platform, 180,000 registered users, and the company itself is about 210 employees. So we've come a long way. Along the way, we had our pivots and our bumps and our bruises. I still have a few to show for it. Back in 2008, right in the middle of the recession, we hadn't been able to attract funding at all. People were not returning our phone calls. There was not, in the VC community and in the angel community, there was a lack of confidence that doctors would move to an electronic system. And looking back, I certainly share that lack of confidence, primarily because there were disincentives for doctors to adopt systems. Extreme disincentives in most cases, especially for the outpatient private practice market. Typically doctor-owned, 15 physicians or less in the practice. They didn't have any money to spend on any sort of technology. They're not trained in technology, so expecting them to know which system to use or which servers they need to buy to store in their office was folly. And when we launched, we went live with $100 a month, or sorry, it was $50 a month to use the product. And after like 3 months, we were doing okay. We were adding a practice every couple days. But we would have doctors call us up and haggle us down from $50 a month, which was just really bizarre, or we thought it was bizarre. And they were literally proposing, how about I give you $20 a month? And what we were thinking was, you really can't afford this extra $360 a year to support your practice and go digital and do all the great things that we all know that electronic health records can provide. You know, saving lives, providing data that doctors can't keep in their heads all the time, lowering costs. And with a little bit more market research, we realized, well, actually they can't afford that additional $360 a year. They are typically saddled with a ton of debt from going to med school for 8 years. They are operating they're essentially running small, medium enterprises, so they have to be able to put some of that money back into their own business. They're not typically great business people, so they're already writing off 30 to 40% of their billables. In primary care settings, which is the main area where we focus, and it's the biggest area that we need electronic health records. It's the biggest market that's lacking them right now. PCPs didn't even see still have not seen their salaries increase with inflation for like 20 years. So they're way behind. Even though they're making 120 grand a year, that really doesn't go very far when you're running your own practice. So they really just didn't have the money, and at that moment we decided to make the product free, but we were going to charge $50 a month for sales and support. 5 days later, we decided to forego that part of our business model because we realized we were setting up the incentives completely wrong. For a doctor to get started using electronic health record, they need help. They need support. They at least need to know that somebody's there to assist them when they reach a roadblock. Whether it's in their workflow or in the adoption process or teaching some of their staff how to use the product. So we were completely misaligning the incentive by charging them for the very thing that they needed to adopt our system. So we got rid of cost altogether, and sure enough, we literally within 3 days, we're starting to see exponential growth. Nothing like making a product free and people come banging at your doors. Now, that was back in late 2007. About a year later was when we hit the recession pretty hard. We weren't able to attract funding, and we were essentially going without pay. I had a couple engineers who kept coming to work even though we hadn't paid them in 3 months. I think that speaks significantly to the mission that we were trying to tackle, this big problem that we knew we had to find a solution for if we were going to take healthcare into the 21st century. And despite them not getting paid, they kept coming. Sure enough, after Obama was elected, the stimulus bill passed in early 2009, so this American Recovery and Reinvestment Act contained the meaningful use section that Rick alluded to, and once we were certified, it became, we were not certified yet, we did not have the functionality that would have allowed us to become certified, but venture capitalists saw that the federal government was making a significant investment in this, and we knew it was going to be good for our business. We didn't know how good. We didn't realize, there wasn't a tangible moment where we knew that this was basically the federal government mandating our software. So that was a very lucky turn of events. We were kind of right place, right time. We had the web-based technology that we knew was necessary to bring the majority of doctors in the US up to the same threshold that the doctors that had a ton of cash were able to provide to their patients. And because we were web-based, we could make the product free by taking advantage of the economy of scale that the internet provides. Even to this day, our margins are quite thick because we don't have to support more than one version of our product. When we release a new version of our EMR or of our personal health record, all of our users are on it. All of our doctors are on the new version, all of our patients are on the new version. We don't have to hire and train support staff to support 10 different versions of the product like Epic does. We don't deploy a huge sales force to go out and convince people to fork over 20 grand just to get started, just to get a place in line. We just provide it for free. You sign up like you would sign up for Facebook or some web-based application. And removing all that friction from the process has been really our secret sauce. We can have a doctor up and running the very morning that they sign up for a product, seeing a patient on our platform, connecting them to their labs, their pharmacies, the billing services, any of their downstream revenue management systems and clinical care products. We can have all that connected in 9 days. The industry average is about 8 months. Because they have to go do this long sales cycle for these products that cost 40, 50 grand, we have essentially eliminated that part, and it's been an extremely disruptive approach to things. We didn't really think of it as disruptive, we just thought of it as bringing 21st century technology to healthcare, but it turns out it's a big, big difference compared to what the other EMR companies have done. For the most part, there are others that have started to go this way. As far as the personal health record goes, we were the first personal health record that was free and web-based, and we did it before it was mandated on us by the government. We knew it was the most important thing that we could do to impact people's health. Without that data, without visibility into your electronic health record, you can't take ownership of your own health. And so providing that information to them at any moment that they need access to it was a core part of our mission, and we continue to deliver on that, competing a bit with the EMR companies that Intuit provides care for, but I think there's plenty of room in the market for a few people to impact the healthcare system. So that's kind of our story. I guess we're ready for questions. I don't know if, yeah.
So Matt, I have many questions, but the first one is, do you have a paid and an unpaid version?
We do. We kept this so-called freemium model in place. We have 180,000 registered users. I can count the number of users that take advantage of our $100 a month on 2 hands. And that's because doctors really don't mind seeing the ads that support our product or participating in the other aspects of our program that allow it to be free. That was one of the more interesting things we learned when we started going to our practices, doctors' offices that had adopted our system. In speaking with them about their usage of the product, they were actually interested in seeing the ads. They saw it as a way to be educated, to learn about new drugs that were coming onto the market that could help them see their patients better. They could learn about the Walmart $4 copay that they could send their patients to that would increase the likelihood that they go pick up that drug. Medication adherence and compliance is one of the biggest problems that we have, partially because patients don't have a whole lot of money out of pocket, but also because they have to go to the pharmacy and wait for 20 minutes or an hour sometimes if the medication is at a different pharmacy. Enabling an EMR system to send those prescriptions electronically became one of the easiest ways, really, that you can increase compliance. But we do have the paid and the unpaid version, and people just don't. What we found is that doctors in the space just do not have the money to pay for any sort of premium, and all that the extra $100 a month buys you is to turn off the ads. And if the ads aren't engaging to you, then you're not going to do it. We don't advertise things like the San Jose Sharks game or the latest BMW sale that's going on. We specifically advertise things that are interesting to our physicians. It's a very targeted system as well, so a physician operating as an oncologist who is seeing a patient with some sort of, let's say, ovarian cancer, the advertisements that we show are specifically focused on medications that could treat that or make that patient better. So I think that's part of the reason.
I think this question's for both Rick and Matt. How do you solve a problem where, say, a patient who's going to your client is going to, say, like the Palo Alto Medical Foundation, and do you see your systems speaking to each other, coming like from like a health information exchange or anything in the future or now even? It's
So what you're describing is what most people refer to as a continuity of care. And I don't think I'm being too overdramatic here when I say it's one of the biggest problems plaguing our entire healthcare system. Let's take Kaiser, for example. They've spent $4 billion on Epic, just buying the technology, and then another $1 billion with a B to implement it. And in consultants and people coming and customizing their systems. Because of the way Epic was built on this old MUMP system, this is pretty standard across most of the old iron technology vendors in the healthcare space that go and install servers in a server room directly on-prem, is that those systems within Kaiser, like Epic, one vendor within the same healthcare system, across 2 different hospitals, they can't even talk to each other. So that there's been so much customization done on these systems that they're not even speaking the same language to each other. That's a kind of a microcosm of the overall communication problem. Now, in stage 1 of meaningful use, which went into effect 1.5 years ago, and doctors have already started recouping money. Doctors can get up to $44,000 over 5 years if they're seeing Medicare patients, $65,000 over 5 years if they see Medicaid patients. Part of that stage 1 meaningful use criteria was setting us up, setting the entire EMR ecosystem up against a common standard that we can communicate against, and it's this continuity of care document, referred to as a CCD. So it's being mandated on the EMR industry to communicate with each other by the end of stage 3. Stage 2 is about to come into play, as he said. There's more, we aren't all the way to the point where hospitals and doctors in private practice can communicate with each other, but it's plugging a few more of the holes, getting some of the plumbing in place so that by the end of 2016, then every EMR vendor should be able to communicate with every other one if they are certified. There's no economic driver in the market that will make it happen now. The federal government had to step in and provide a direct mandate for it to occur. It would have been nice to see the market develop that itself, but I would say generally the market failed. And that is the reason that the stimulus bill included all this money, was because the existing market had completely failed doctors and patients ultimately.
Yeah, well put. The only thing I would add to that is, in meaningful use 2, there's a requirement to allow patients to then engage in this. And you can, we need to give the ability, and I'm sure you'll do it as well, for a patient to be able to view, download, and transmit their data. And there's actually something that the government is pushing for, which is something called Direct, which is essentially a encrypted email type structure. You're more technical than I am, Matthew.
It's
but,
an okay. It's an okay way to put it.
and basically, so I could show you a prototype of it today, that you can not only download your own data onto your hard drive in this format, in the CCD format, but you can also transmit it. And one of the problems today is the different health information service providers don't speak the same language, and so that still has to get worked out, but you'll be able to, on our system starting in January, enter a direct address, you the patient, and say, I want my data transmitted there. And that again is going to liberate things. So even if a third party is not integrated with us, technically the patient will be in control, and they can say, I want to take all my records and transmit it to a LiveCore. And then a LiveCore can use that data inside of their app to offer a better experience for cardiac care. Or they may say, you know what, I'm going to a doc that uses Practice Fusion, and Practice Fusion invariably will have, probably on your roadmap, the ability for the patient to import in a CCD, and so they could send it basically to themselves, their own record. So again, this whole liberation of data is a common theme that's going on.
I have a policy question. Can you hear me?
Yeah.
Okay. In January, we're going to get a president. Now, if Obama is re-elected, my question to you guys is, what is the impact in each one of you, what you are doing? That's one question. But if the Bozo is elected, I'm sorry, if Mr. Romney is elected, then what will the impact on your business?
So I can go first. In both cases, we don't see a big impact taking place. I should be careful. In the healthcare business of Intuit, we don't see a big impact. In our TurboTax division, I can't speak for that. That's a multi-billion-dollar business that is very impacted by what happens with taxes. And so if someone goes to a flat tax, the Intuit stock price will be impacted. But so in both cases, I don't think anyone's talking about repealing the the ERA bill and with meaningful use. That's not being contemplated. The dollars have already been paid out. And certainly, I will say though that the advent of Obamacare, as it's called, there's some provisions in there for accountable care organizations and many more people having access to insurance and be able to coverage. So that'll just stress our system more, which will bring more dollars to provider organizations, which I think helps all of our businesses. But I don't know, what do you guys?
So one thing that we're trying to do at the LiveCore is we're actually trying to step out of the reimbursement environment altogether. So in a way, we won't. I think we'd be affected in terms of more dollars in to providers, more people insured. We might have our device such that if it's prescribed by a doctor, that the patient could get reimbursed for it. But the pricing of our device is such it's actually for a medical professional less than the cost of an electronic stethoscope. So once you have it, it can be used on unlimited patients. So we actually are sort of, we may be more affected by kind of insurance models, but from a reimbursement model and a Medicare model, we're actually both for the medical professional trying to price this such that it's something that they would decide to buy on their own, And for patients and consumers, because we will actually be applying for an over-the-counter application, we're actually trying to take reimbursement out. So you as a patient or consumer, we're looking at some very interesting models for allowing you as a consumer to be able for 20 cents to get an interpretive algorithm and to actually get the price of a human overread, 4 of them for the price of a copay. So we're not sure we're gonna get there, but we're trying to make it such that you will actually be choosing to pay yourself directly rather than kind of ways just as you're able to provide something for free, such that the whole reimbursement model actually isn't even a part of our business model.
So it will not be impacted either way.
Yeah, so we want to be impacted either way.
But yours.
We're getting pretty wonky here. I wasn't expecting that. It's similar to what Rick said. The meaningful use aspect, the so-called High-Tech Act piece of the American Recovery and Reinvestment Act is a bipartisan issue. George W. Bush was pushing for electronic medical records and the government funding doctors getting into this, using more electronic systems to track their patients' health. So that will never be affected, especially since it's a political winner. Both sides recognize that we need this, and this is a fairly reasonable way to pay for it. The way that the structure is set up within Medicare and Medicaid for payments, this money is tucked away. It's not part of any other bill. So it's more than just earmarked. It's protected. If Medicare, if Paul Ryan's budget, which would pretty much dismantle Medicare as we know it, takes into shape, then that would be an interesting. That would be interesting. It's unlikely that would take effect until after the meaningful use dollars have been completely paid out, so by the end of 2016. But that'd be an interesting thing to see what they do with that money if Medicare is no longer available in the way that it is now, if it moves to a voucher system. Now on with regard to Obamacare, electronic health records are seeing and will see over the next 4 years as the accountable care organizations come into play, and there's more incentive for EMR vendors to communicate with other EMR companies. There's likely going to be more patients going to see physicians, so they really need more electronic health records, more functionality to help them manage their patient populations with less time to spend with each patient. They need to automate as many things as possible. There's just so many hours in the day that doctors can learn about new drugs that are on the market or new therapies that they can provide to their patients. On an electronic system, a lot of that stuff is taken care of for you. So I could see demand being a little bit higher, but there's already a pretty decent incentive for most doctors to get started. The most damage, I would say, that could possibly be done to the current way the healthcare system is set up was done in Justice Roberts' ruling to get rid of the Medicaid, the additional, like 7 or 8 million people that are no longer insured as part of that Medicaid exemption. But that doesn't really affect us too much, except the consumers of the healthcare are not as, they're just not covered quite as much, about 2% less when you look at the overall population.
So except for Medicaid and Medicare, basically saying it's not that much impact.
Yeah, we don't see much impact.
I will make a plug for a local company, Vimo, which is started by a guy named Shankar Srinivas, and they are very impacted because they are running, basically they're set up to run an exchange. They're based in Mountain View, and so if the exchanges actually come to play, and that will be impacted, even though the Supreme Court said they will, that could easily still get unwound. But Vimo, I know, is hiring and has a great business model and an interesting product.
I have a question about privacy generally. I know people are very paranoid about privacy around healthcare. And I heard this concept of CCDs. And is it being used in any way by consumers/patients? And is privacy a barrier to adoption?
It is, but less and less so, I would say. Certainly in 1996, when I joined Healthion, which became WebMD, and we were initially doing some very early versions of personal health records and making data available online, there was a lot of angst about privacy. But now with everything being online and such, and the HIPAA laws that actually were enacted in 1996 were the beginnings of a lengthy, now 16 years of healthcare privacy legislation, and there's been prosecution and fines over the years. It is less and less, and there's all of our data, for example, when it comes into our data center like this CCD, it's governed by what's called a business associate agreement that I have with the provider organization. And so if someone were to hack into my database, there's liability associated with it. And so it's stored in a very secure manner, in our case in the same place we store your financial information for TurboTax. So my perception is it's largely been overcome, but I think we are going to see more. There have been recently, and there will continue to be situations where data is compromised, and but if there's penalties associated with that, and those companies will be gone in a heartbeat, I think. That's my perspective.
Well, I think the only thing is we have the additional complexity of having the mobile device and the data on the mobile side, so we have all of the complications or requirements of the cloud and our website and our data there, but also the additional complication of, if a doctor's using his phone and storing all those ECGs and then loses his or her phone, what happens there? So certainly we know we're using one of the leading law firms on HIPAA compliance, and her partner there says we're a textbook case for kind of some of the stuff that they're wrestling now with around mobile devices and the fact that you have all that data, and that is personal health data sitting on your phone. So.
Yeah, the great irony with privacy in healthcare is that study after study has proven that the more people you share your health ailment with, and your goal in losing weight or stepping back from the ledge of getting close to coronary artery disease, the more people you involve in that conversation, the more likely you are to get better. So when people talk about privacy, the first thing I think about is, well, really should it be that private? Should it be something that we protect and consider just the Fort Knox of your health data? And I think we would all do ourselves a favor to come a little bit toward the middle of the spectrum when it comes to your health information. We as patients should all have the right to determine who has access to our data. I think that's sort of a core principle. That doesn't exist today, though. There's no requirement within HIPAA that your doctor tells you what he or she is doing with your data, what he or she is, where they're sending your information. There's sort of a flimsy HIPAA consent form that has almost no meaning. They may tell you, and they may do it to protect themselves, but there have been very, very few cases brought in front of the Office of Civil Rights within Health and Human Services on individual bases when people complain. It's the broad, it's the big data breaches, the big security breaches that get the most press, and that's what the government's going to go after because it gives the most bang for their buck from a punitive standpoint. But the serious healthcare companies, the serious electronic health record companies that want to stay in business will take privacy very seriously, will be very upfront with their providers and with the patients that are being managed on their platform about what the data is going to be used for, and that's been our philosophy, that we gain nothing by being shady about what we're doing with any of the information or how our doctors are using the data. It's all in line with our mission of democratizing healthcare, making it available to the masses at the same level no matter your income.
My question was more towards the consumer perception, because if you're going to get a lot of information from the consumer and consumers pushing around the data, so there's always a scare about, I'll get discriminated at work, I'll get discriminated during insurance. So I can see a lot of potential in consumer owning the CCD and moving it around, especially because you might go to multiple providers who belong to different systems, and you might be the only person kind of confusing everything. But at the same time, maybe there's this perception as well.
Yeah, again, I don't think we've gotten past that, and we Intuit have done a fair amount of research as to, in this topic area, and if anything, patients are picking, and there's data to show that they're switching doctors because they have a better online system. And you know, that they want this. And nothing requires the patient to download their data and engage in this. Because there are some, like my brother, who's super sensitive to this, and you know, he won't use Mint because he's not going to upload his user ID and password to any third-party company, and that's going to continue to exist. But I don't think it's an impediment to startup companies, as long as you do what Matthew said and safeguard the data.
I have a question here. First, Tom?
We can hear you.
Okay. So first of all, for the audience, please wait for the mic before you ask the questions, because first, we can't hear you, and secondly, he can't pick it up on tape. Thank you very much for coming to TIE and sharing your knowledge with us. This question is for Judy. Where are you in the FDA process? You might have mentioned that, but more importantly, how do you sell? What's your go-to-market